First of all, I would like to say thanks to Dr. Ram Pratap Singh Mandela sir for inviting me and giving this and all this perspective in era of third space endoscopy. I will discuss this topic in following areas in brief: type of dysphagia, then clinical approach, diagnostic modalities, and case-based discussion, mainly gastroenterology perspective. So, first definition of the dysphagia, that is difficulty in the transferring food from the mouth to the stomach. In simple language, we can say difficulty in the swallowing. So dysphagia can be classified oropharyngeal, esophageal, and structural causes. Oropharyngeal dysphagia means difficulty in the emptying of the food from the oral cavity to the esophagus, and the common cause of the oropharyngeal dysphagia are neurological and skeletal muscle disorder, and these are the mainly related to ENT or neurological part. So I will mainly discuss about the esophageal dysphagia, that include motility disorder, mechanical causes, and structural causes. Motility disorder includes Achalasia, cardia, diffuse esophageal spasm, and jackhammer esophagus. Regarding the mechanical causes of the esophageal dysphagia, it could be inside the lumen, it could be within the wall, and it could be outside the wall. Inside the lumen, the common cause, foreign body or food bolus impaction. Within the wall, it could be benign or malignant cause. Benign cause could be peptic strictures or esophageal valves, rings, and also it could be carcinoma. And outside the wall, sometimes outside mediastinal tumor, lymphomas, or lymph nodes can compress the or obstruct the GI, the esophageal lumen, and patient can come with the dysphagia. Few structural causes, like sometimes osteophytes, especially in the old age group at the cervical region from C3 to C7, can enlarge and patient come with the dysphagia. And lastly, Jenker's diverticulum. Jenker's diverticulum is the mucosal outpouching in the upper esophagus between the two muscles, inferior pharyngeal constriction and the cricopharyngeal muscle. So now coming to the clinical approach. First we have to identify the location, whether patient is oropharyngeal and the esophageal. So clinical point for the oropharyngeal dysphagia, patient start symptom just at the initiation of the swallowing, and patient can be associated, symptom can be associated with the regurgitation more commonly. Patient can have cough and aspiration during the swallowing, and patient usually point symptom toward the neck side. And for the esophageal dysphagia, patient start dysphagia symptom after few seconds of the swallowing, and patient can have regurgitation of the undigested food, and patient point symptom either suprasternal or retrosternal area more commonly. Now coming to the esophageal dysphagia. So first point we have to identify either patient has dysphagia for solids only or patient has dysphagia for solid and liquids from the beginning. So if patient has dysphagia for solid, the mostly causes are the mechanical. Then second point, we have to assess whether it is intermittent or progressive. Intermittent solid dysphagia is more common associated with benign disease like esophageal rings, esophageal valves, and esophageal esophagitis. Eosinophilic esophagitis. If dysphagia for solid is progressive, then we have to assess if patient has reflux symptom or progression is very slow and not associated with the significant weight loss, then likely cause is benign, mostly peptic stricture. If the progression for solid dysphagia is rapid and associated with significant weight loss, obviously patient can have malignancy in the esophagus. If patient has dysphagia for solid and liquid both from the beginning, the chances of motility disorder is more common. And if patient has progressive symptom along with the regurgitation, then you can say the chances of achalasia is more. If patient has intermittent symptom along with the chest pain, then spasmodic disorder like distal esophageal spasm and hypercontractile esophagus can be the cause. Coming to the diagnostic modality, it can include endoscopy, barium swallow, endoscopic ultrasound, imaging like CT, PET scan, and high resolution manometry. So endoscopy is the first and most important investigation to diagnose the causes of the dysphagia, and also many causes of dysphagia we can treat only by the endoscopy. So I will share few diagnoses on the basis of the endoscopy. In first image you can see this patient has intraluminal cause of CA esophagus. In second image you can see the classical reflux ulceration, linear ulceration along with the stricture at the GE junction. This is the peptic stricture. If any patient has history of corrosive ingestion and come with the dysphagia, you can do endoscopy, and if you find a stricture that you can say this is the corrosive stricture, and you can also treat these stricture by the multiple repeated session of the dilatation by endoscopy only. You can diagnose Achalasia cardia on endoscopy. Then one of the most common esophageal infection, esophageal candidiasis, where you see whitish plaque or exudate over the esophageal wall, and you can diagnose esophageal valve and Side-Ski ring on endoscopy, and again you can do the multiple session of dilatation if required to treat dysphagia because of these causes. In eosinophilic esophagitis, we see usually this classical typical finding on the endoscopy, multiple concentric ring, and if you see this finding, you can take biopsy to establish the diagnosis of the eosinophilic esophagitis. And obviously, foreign body impaction you can diagnose and you can remove by the endoscopy. But if any patient has extraluminal compression in the esophagus or patient has dysphagia, so in this case, if you take biopsy from this area is the almost normal mucosa, so you will not get the diagnosis. So in these type of the cases, you need other investigation than the endoscopy, and that is the endoscopic ultrasound. So we will discuss regarding the endoscopic ultrasound in the coming slides. Now I will discuss few cases so that we can understand better regarding the dysphagia causes and the newer advanced treatment related to endoscopy. So case 1, 48-year-old female who had difficulty in swallowing for both solid and liquid since 2 years, and associated with the regurgitation of the undigested food, and also has retroesternal chest pain. So first investigation, as we discussed, endoscopy, and endoscopy showed finding dilated esophagus with tight LES and food stasis in the esophagus. So these findings are classical for the Achalasia cardia. So what is Achalasia cardia? Achalasia cardia is a disorder where incomplete lower esophageal sphincter relaxation along with the abnormal esophageal peristalsis that can lead to the LES obstruction and the progressive dilatation of the esophagus. These are the various types of the Achalasia cardia. For type 1, where is absent peristalsis with tight LES, and type 2 there is pan-esophageal pressurization, and type 3 spastic contraction almost in the entire or half length of the esophagus. So we need to diagnose these different type of the Achalasia on the basis of other investigation, and this investigation is high resolution manometry. So high resolution manometry, what is this? So in this procedure we use a catheter with multiple closely spaced pressure sensor that can measure esophageal and the lower esophageal sphincter pressure, and these pressure are displayed on color coded plot which can be analyzed on the computer screen with precise interpretation. You can see in the second image. So on the basis of the high resolution manometry, we can diagnose the different type of the Achalasia, type 1, type 2 and type 3. And also other than Achalasia disorder like hypercontractile esophagus and distal esophageal spasm, we can diagnose on manometry. These disorders can also present with dysphagia and intermittent chest pain. And manometry is required because this is the gold standard investigation to diagnose Achalasia cardia. And one more important thing, for the treatment of the Achalasia, we do the myotomy. So decision of the myotomy length, again we need manometry. So if you diagnose type 1 and type 2, we need short myotomy. If we diagnose type 3 Achalasia or other spastic disorder, then we need longer myotomy. Next investigation we can do in this case is barium study. So, but barium swallow is not required in all cases of the Achalasia cardia. So where do I use this test? If any patient presents with equivocal esophageal manometry result, then only I will do barium swallow in this case. And what are the findings? You will find hugely dilated esophagus along with bird weak appearance. This is quite classical for the Achalasia cardia. So now diagnosis is established. In this case, the patient has Achalasia cardia. So patient will ask the question, doctor, how will you treat my disease? Then you have a diagnosis. So the best treatment option for the Achalasia nowadays, two options are there. First is per oral endoscopic myotomy and second is the Haller's myotomy. So laparoscopic Haller's myotomy is minimally invasive laparoscopic well-established treatment for the Achalasia cardia from the long time. I will discuss regarding the per oral endoscopic myotomy. This is the third space endoscopic procedure. The question is, what is the third space? So in this first diagram we can see GI lumen is the first space, and second peritoneal cavity can consider second space, and the space created within the wall of the GI wall, this is the third space. So in this photo you can see I think it's not working. So in this image you can see this is there is incision in the GI wall, and above one is the mucosa and lower one is the musculus propria, and this space is the third space, and this is the working space for the third space endoscopic procedure. In this animated video, we can see the basic concept of the third space endoscopy. So this is the GI wall including mucosa, submucosa and the musculus propria. So what we do, we give methylene blue mixed saline injection in the submucosal space, and after this we give incision in the mucosa. Then we create a submucosal tunnel, and if problem lies in the musculus propria, then we do the myotomy like in the poem. If patient has forward ticker. So if patient has tumor in this area, then we can remove the tumor from the all around. We can dissect from the all layer and finally remove from the tunnel, and finally we can close this defect. Then I'll show you a small video of the poem per oral endoscopic myotomy procedure. First we give the mucosal submucosal injection to create a blab, then followed by we give a mucosal incision. Then we enter in the submucosal tunnel, and by dissecting the submucosal fiber, we create a tunnel beyond the GE junction, and after that we do myotomy across the GE junction, and after the completion of the myotomy, we can close the defect. So this is the poem procedure. Then next question patient can ask, doctor, what is the best treatment option among these two options? So you can say poem procedure is safe, and these are the benefits of poem procedure. It's a very safe procedure. I hardly see any complication after the poem procedure. Recovery is quite quick. You can send the patient home next day of the procedure. Patient can eat next day of the procedure, and there is no recurrence. I hardly see any recurrence after the poem. And in fact, this study published in NEGM that suggests the poem has almost equivalent or superior results if you compare from the Haller's myotomy, and the chances of the severe adverse event is quite low with poem procedure. Now coming to the second case, 76-year-old male who has regurgitation along with the halitosis, with patient also has dysphagia and history of pneumonia. Endoscopy was done with the Jenker's diverticulum. Jenker's diverticulum is a small pouch in the upper esophagus, near the upper esophageal sphincter. Their food can stuck, and patient can present with the regurgitation and difficulty in the swallowing. So in this diagram, first diagram, you can see in the center septum. This is the problem. We have to divide this septum and make one lumen. So older treatment like endoscopic diverticulotomy and the surgery can have higher chance of the recurrence and complication. So we have a new procedure. This is the JAD poem, JAD per oral endoscopic myotomy, where what we do, first we give submucosal injection just above the septum, then followed by we create an incision here, and then we make a tunnel both sides of the septum toward the diverticular and esophageal side, and after that we do the septotomy, myotomy of the septum, and finally we can close the defect just like routine poem. So And success rate of JAD-POEM is quite good, more than 95%. Coming to the next case, 64-year-old female with presented with the dysphagia more for solid. Since 1 year, endoscopy showed large subepithelial lesion at GE junction. Because of that, patient has dysphagia and biopsy showed GIST. So we have another third space endoscopic procedure. The procedure name is the submucosal tunneling and endoscopic resection. Here what we do, we make a tunnel like this. In first image you can see. Then after making the tunnel, we remove the tumor from the all around, and we remove this tumor from the tunnel, and finally we close the defect. So by this stir procedure, we remove this tumor from the GE junction, and the size of tumor was around 3.5 centimeter. I will discuss another case, 78-year-old female who has retrosternal chest burning sensation and regurgitation, and occasionally patient had dysphagia. And on endoscopy, there was a doubtful area in the lower esophagus. So we have another advanced endoscopy technology, that is the image-enhanced endoscopy. So with this latest endoscopy technique, we can identify the microsurface and microvascular pattern in the GI wall, in the esophagus and gastric wall, and you can identify the early gastric or early esophageal cancer. And not only we diagnose, now these type of the early GI cancer we can resect by the another third space endoscopic procedure, and that is the endoscopic submucosal dissection. I'll show you this small video. So this was the same case. This patient has a doubtful lesion in the lower esophagus, and on NBI examination, here you can see this patient has abnormal microsurface and vascular pattern. Here you can see, and after that the lesion was marked from the all around to get R0 resection, and after that submucosal incision was given here just above the lesion, and finally this lesion was dissected from the all around, and this was the resected specimen around 3.5 centimeter in size. So another case, patient has a 78-year-old male who has difficulty in the swallowing, more for solid, and that is progressive in nature, and patient has significant weight loss, more than 10 kg in last 5 months. And endoscopy showed asymmetrical thickening at the GE junction. This is most likely the malignant one. Then endoscopy biopsy was done in this case, but biopsy was negative. It is most likely because of patient has almost normal mucosa over this malignancy. So in these type of the case, we need another investigation, endoscopic ultrasound. Endoscopic ultrasound, by use of endoscopic ultrasound, we can look outside the GI wall, and you can take biopsy from the outside of the GI wall. In this image, you can see this is the asymmetrical thickening, and you can take biopsy from this area by the endoscopic ultrasound, and biopsy was finally adenocarcinoma. Then CT abdomen was done to rule out the metastasis, and this patient has multiple nodes, including the para-aortic node. So the diagnosis of patient is inoperable CA esophagus. So this patient required palliative treatment for dysphagia now, and what we can do for that, we can place this metal stent in this case, covered metal stent across the luminal narrowing site, and after that patient can able to eat without any symptom of dysphagia. Now coming to the last case, 28-year-old male who doesn't have any comorbidity. Patient had significant evening rise temperature with unintentional weight loss, and patient had dysphagia more for the solid. So he is young patient. Montauk was done to rule out TB. Chest CT was done. So Montauk was positive, 22 mm in duration with multiple lymph node in the chest. So in this case, again we need endoscopic ultrasound, because if you see the endoscopy, the mucosa is normal. There is only compression from the lymph node in the esophageal lumen. So in this case, US was done, and you can see here the conglomerated large lymph node in the subcarinal or mediastinal area, and FNA was taken from this lymph node, and that shows the tuberculosis, and this patient treated with the anti-tubercular drugs. So coming to the conclusion, endoscopy has refined the management of the dysphagia, and gastroenterologists can venture into the domain previously thought to be only surgeon space, and many diseases can be treated scarless by modern endoscopic procedure like third space endoscopic procedure, and these are minimal invasive procedure, and these techniques offer faster recovery, feasibility in high risk patient, and excellent clinical outcomes. So now we can say endoscope is the new hope in the treatment of the dysphagia. Thank you very much for all of you for your kind attention.
Any query from our chairpersons? Please kindly go ahead.
My dear, even sometimes he used to say, she tell that she was having the regurgitation at the night time also, and lot of the investigation were done, including the various also. But we are inconclusive. So how to approach in this type of the patient? Can you tell me? Its age is 13 years. So
13 years.
No weight loss. No weight loss. Hemoglobin was absolutely normal. Liver functions and each and everything is very normal. And even X-ray chest is normal. What to do?
The patient has symptom of dysphagia for
Yeah,
solids, more for solids.
Both the things. Both the things.
So if your patient is quite young, chances of malignancy is quite low in this case, and again patient has dysphagia for both solid and liquid. So if any patient has dysphagia for both solid and liquid, the chances of motility disorder is high, and in fact the age group is matching. We see lot of patient of achalasia and lot of patient of other than achalasia disorder like distal esophageal spasm in younger age group. So in this case, we should do a careful endoscopy first, and if you find diagnosis on endoscopy, that's okay. And if you don't find, then I think next investigation should be esophageal manometry in this case. In most of the cases, we find diagnosis on esophageal manometry in these type of the cases. One more group I think I need to discuss here. Sometimes patient can have a symptom of dysphagia, especially in young age group, with solid and liquid also. Patient can complain for both. And if all investigation are normal, like you said barium was normal, endoscopy was normal, if manometry, CT scan, everything is normal, that could be functional dysphagia also. So patient can present with similar history, and if all investigation are normal, we can consider these patients with functional dysphagia. Some patient can have the symptom of lower sensation in this area. I think, but before labeling any patient to functional dysphagia, we should rule out by doing all investigation.
Because we have seen that all his parents were also very much concerned. There was a regurgitation of the food, and she used to spit it out.
Yes.
So we have requested for the manometry with our senior colleague. So I have sent her for the manometry.
If concern about the regurgitation, if any patient has dysphagia and regurgitation more at the night time, again the chances of motility disorder is high. So this patient should get esophageal manometry. I think we should rule out Achalasia cardia in this case. Definitely.
And one more thing, we are getting a lot of patients after getting the viral fever in the very young age group, especially between the 6 to 10 years of age. They are having the nasal regurgitation along with the asymmetrical palatal movement. So is it the post-viral unilateral vulvar palsy what we are facing? Because the voluntary procedure, what we call it during the swelling, we start with the voluntary procedure, then we move to the reflexive phase. So that voluntary initiation is almost gone in one side. So they have this type of the problems. Even they get the continuous coughing also. And even I have seen the people with the pneumonia also. So what to do in this type of the patient? Do you have to wait to get it recovered by the steroid or something, or what other things we can do?
I think the cause of dysphagia and the regurgitation and pneumonia in this case, in these type of cases, is only because of infection like viral. So we should treat infection for a particular period of the time. Most of the patient can improve, but again, if I get any patient with oropharyngeal dysphagia, I usually refer the patient to ENT department or neurology department or rheumatology department, depending on what is the diagnosis. So I don't have much experience regarding the oropharyngeal dysphagia, but I think if any patient has viral infection followed by dysphagia, regurgitation and pneumonia, we should treat underlying pathology, we should treat pneumonia and other things with the help of antibiotic, and we should wait for that.
So such type of case, we put it right to you, and regurgitation due to the palatal palsy. So it can manage 2 to 3 months after. So nice presentation, Dr. Khare, and
in elderly patient coming with dysphagia, should we go for upper GI endoscopy first or barium swallow for them?
In upper GI endoscopy, you can get many diagnoses. And if you get any finding, like in elderly patient, the most common finding you will get a malignancy. So at the same time, you can take biopsies also. So you can get better diagnosis with upper GI endoscopy. You should do upper GI endoscopy. You should refer patient, or you should do upper GI endoscopy first before doing barium.
Thank you.
Thank you so much for such an educative talk. I think no other questions.
one more question. In Achalasia cardia, what is the chances of recurrence?
In
Achalasia cardia.
After
yes.
after poem procedure.
Yeah.
So I have done around 400, 500, between the 400 and 500 cases in the last 5 years of the peroral endoscopic myotomy. So I don't see recurrence in a single case. I think recurrence is quite uncommon after the peroral endoscopic myotomy. The only problem is sometime if anybody do poem and if there is inadequate myotomy, then patient can come with recurrence. If you do the adequate myotomy beyond the GE junction, 2 cm beyond the GE junction, the chances of recurrence is almost nil with peroral endoscopy.
You are doing the circumferential or the longitudinal?
So I used to do full thickness myotomy, especially at the GE junction, both for circular muscles and also for the longitudinal muscles.
You are doing the circumferential or the longitudinal?
Longitudinal.
In case
so there are two approaches for the poem, anterior and posterior. So most commonly performed approach is posterior myotomy, and we do only longitudinal.
In case of stricture, what is the process of management?
Stricture. So again, I think first we should start from the history only and clinical examination. If any patient has suppose this patient come with a dysphagia more for solid, the stricture usually present with a dysphagia more for solid, and patient has a reflux symptom, and
in such a case like H2SO4 or corrosive,
if any patient has
and progressive stricture, then what should be done?
In corrosive injury, I think first we should treat the patient without any doing endoscopy and endoscopic treatment. Just wait for a few weeks, 1 week or 2 weeks with the supportive treatment. Just put rice soup for the feeding, and after 2 weeks, you have to assess your patient again. If patient is okay, patient can able to eat, then no need to do any endoscopy. If patient has symptom, then you need to perform endoscopy, and then again you have to assess if stricture could be a simple or the complex. If simple stricture is there, then easily you can manage with the multiple endoscopy dilatation. 2, 3, 4 sessions are, I think, sufficient. But if patient has complex stricture or your patient is not responding with the dilatation, suppose you have done 5 sessions of the endoscopic dilatation, then and patient is not improving, then you can put a fully covered metal stent in the esophagus for at least 4 weeks. And I think this is the algorithm or protocol to treat corrosive stricture. And if again patient is not responding or patient can develop symptom even after removal of the stent, then you have to refer your patient for surgery.
In such corrosive patients, is it safe to put rice tube blindly without endoscopy, without assessing?
Very good question, sir. You are 100% correct. We should not put the rice tube without any X-ray or imaging. First, we assess the patient. If your patient is stable, if your patient doesn't have any sign of toxicity or tachycardia, BP is okay, then you can try. But always, I think always we should get at least X-ray before putting the rice tube in the corrosive region.
No, X-ray will tell only the perforation.
Yes.
But suppose there is high degree of mucosal damage, and while attempting the rice tube, you may perforate it.
So I think in this situation, you should assess your patient clinically. If your patient clinically is okay, you can put rice tube, or if your patient is not clinically okay, then you should do further investigation before putting the rice tube. And there is no need to hurry to put rice tube on first day of the corrosive injury. You can wait at least 2 or 3 days, 48 hours, 72 hours are okay with IV fluids and other supportive treatment. These patients are usually quite healthy and have good nutrition, so you can wait for 2 days, 3 days. That's okay. If doubt is there for perforation, then you can do your endoscopy under CO2 guidance, and you can place a wire in the stomach or in the duodenum. Then over the wire you can place a rice tube or angiogram.
We are more worried about hydrogenic perforation while inserting the rice tube.
Actually, the mucosa gets edematous. While putting a rice tube, there are high chances that we might perforate. Even about 48 hours.
No, in my experience, the chances of getting perforation from the rice tube is very, very minimal. If I get patient, if I think the rice tube is required, patient is okay, I can put rice tube,
You can check it afterward also whether it is very right position or not.
So on bedside you can check. I think there is no need to do anything else than just putting some air from the 50 ml, 50 cc syringe.
Even the rice tube is relatively safe.
Rice tube is, you can put rice tube, that's okay.
Before going an endoscopic assessment.
No, so again, I think you should assess your patient clinically, okay, and just wait for 48 hours, 72 hours. If you think your patient is stable, you can put rice tube. There is no significant injury. X-ray is normal. You can get also CT scan. CT scan is okay. Then you can put rice tube, and rice tube most likely will not do anything, any injury in the mucosa. If you still worried regarding the perforation, mucosal injury, because of your patient condition or something else, then you can do endoscopy guidance. In endoscopy guidance, again you should remember, just do endoscopy only with CO2. Don't do endoscopy with air. If there is any perforation, air can complicate further. So just do with CO2, under CO2, and put wire, and over the wire you can place rice tube.
Thank you so much.
Any other query from the audience? Thanks, Dr. Shivam Khare, for deliberating such a wonderful talk. कि जिंदगी के लिए अरमान जरूरी है, जिंदगी chairpersons and the moderators. So I request to do honor to Dr. Vinita Savas and do honor to Dr. Puspendra Agrawal. Dr. Puspendra Agrawal. Amit Kumar Jain. Give a big round of applause to honorable speakers. Dr. Puspendra Agrawal. Dr. Harendra Yadav.
Wait here. Wait. Sir, यहाँ देखिएगा.